When are you too old to have a colonoscopy?
Is a 40-year-old too young to have colorectal cancer?
Our guest on this week's Health Talk will answer these questions and more.
Stay tuned. We're up next. Hello, I'm Dr. Vicki Smitak.
And I'm Dr. Eric Mazer. Today we're going to discuss colorectal conditions and colorectal cancer with colorectal surgeon, Dr. Jung-Ho Shin. Did I get that right?
Yes.
Welcome to Health Talk.
Welcome
Thanks.
to the show, Jim.
And welcome to Norwalk Hospital and to Southern Connecticut. I know that you've been here just a couple of months. New surgeon, we're so glad to have you.
Glad to be here.
So colorectal cancer is certainly a very broad and very daunting topic, but why don't we start with some of the basics? For example, I always like to know about risk factors, right? So who's at risk for developing this disease? And then we can get into some of the other issues as well.
Okay. So colorectal cancer is a cancer developed from a precancerous polyp, and it can happen anybody. Currently, there is 2 or 3 well-characterized inheritable colorectal cancer syndromes. Other than that, people with inflammatory bowel disease such as Crohn's disease or ulcerative colitis can be at increased risk for colon cancer. If you have a first-degree relatives who has colon cancer, you are at increased risk of developing
And maybe
colon
for our
cancer.
viewers at home,
Right.
tell them what a first-degree relative means.
So your parents, siblings, and cousins.
So not necessarily the great uncle that you've heard about that may or
Right.
may not have had it, but
Mhm.
really a close relative.
A close relative.
Okay.
Yeah, that's very interesting because even though these hereditary syndromes that we know are so prominently polyposis coli and the non-polyposis hereditary, most of them are not related to those clear hereditary syndromes. They're just out of nowhere.
Correct. Only about 5% of all colon cancer is related to the heritable polyposis cancer syndrome.
And yet on the other hand, you have there clearly is a common, or I should say a more common instance when you do have it running in families, but you don't have this clear genetic pathway that you can follow. So maybe say a little bit about, it's not just that your relative has cancer, it also has to do with when they get their cancer. It changes your risk. Maybe you could say a few words about that.
Correct. So if your relatives, close relatives, have a colon cancer before the age of 50, the likelihood that you inherit certain type of predisposed genes is increased.
Okay.
Yeah, so younger cancers are bad not only for the person who gets them, but
also
in
for their
general,
family members.
it's a bad prognostic, or I should say, it increases the risk of their relatives because they tend to be more genetically oriented.
Right. Is there a predisposition more for males versus females to get this type of cancer, or is it sort of evenly split down the middle?
Yeah, it is evenly split.
Okay, so this is one of those
This
cancers
is
where
an
the sex
equal
really doesn't
opportunity
matter.
cancer.
Yeah.
Yep.
And it's certainly, I think a big part of the reason we're here to talk today is because this is a cancer that's really preventable, right? If caught at an early enough stage.
Correct. The colon cancer incidence in the United States, which is about 150,000 cases per year, has been steady for the last 2 decades. And that for the last 2 decades, the rate of screening colonoscopy has been increasing. So that tells you that the colonoscopy really saves lives and prevents the colon cancer.
Are we seeing the death rate actually decrease with colorectal cancer, or is that steady as well?
The death rate has been slowly decreasing, but has been steady. What's a little bit alarming for us is that for the last decade, the incidence of the rectal cancer, not just the colon cancer, but rectal cancer among the patients who's younger than 40 years old has been slowly increasing.
And we don't understand why that's happening. And maybe you could say a few words, because I think a lot of people, myself included before I went to medical school, thought of the colon and the rectum as all part of the same thing. What's the difference between rectal cancer and colon cancer anatomically?
Right. So colon and the colon is about 5 foot long, and it starts from your right side with the cecum and runs around and comes down to your pelvis. And once it gets into the pelvis, it becomes a rectum. The major anatomic difference is the rectum is a fixed position in the pelvis, and there is no small intestines or important structures around it. Therefore, the radiation to the rectum is possible with a relatively less toxicity to the adjacent organs, whereas the radiation to the colon is not possible.
I know you said that we don't really know why this incidence is up in terms of younger people getting rectal cancer, but are there any thoughts or is there any speculation as far as what potential mechanisms might be, or is this all just very new and we don't have any ideas?
We don't have a clear or scientific
Right.
based ideas, but the speculation is that colon cancer is related to the the diet, the exposure to the carcinogens in our food, and whatever we ingest and consume. So that's just a speculation.
Yeah,
Okay.
because the incidences are different in different parts of the world, aren't they?
Correct. And now if you look at the colon disease, interestingly, something like diverticulitis, which is unheard of in the parts of Asia about 2 decades ago, it's been steadily increasing as their diet becomes more westernized and they consume more animal fats.
So the culprit really seems to be animal fat, increased animal fat in the diet, or are there other dietary culprits that have been identified?
I think it's animal fat, especially the red meats, and
Yeah.
also the processed food and sugars in our diet.
Generally the sugars in our
Yeah.
diet.
Now, for a while, I remember back in medical school, Dennis Burkitt, the famous Dennis Burkitt of Burkitt's lymphoma, actually came and lectured to us, and he believed very strongly and showed some very interesting pictures that fiber in the diet, fiber in the undeveloped world was helped prevent colon cancer by increased colonic transit and decreased red meat. But I don't think the fiber hypothesis is borne out. What's the latest on fiber and colon cancer?
The fiber certainly prevents or decreases your risk of colon cancer because the fiber is the main thing that kind of balances your environment in the bacterial flora in your colon. On the last few years, there has been an increasing interest in terms of understanding the bacterial milieu of the colon, and that's a relation to the disease, not just the colon cancer, but cardiovascular disease and other disease as well. And I think the more fiber you ingest, you normalize your bacteria, and you foster the more benevolent bacteria in your colon.
So it's still good to eat high fiber diets.
Absolutely.
Good. I'm glad we're getting that message out there and we're not dispelling that.
Now, I know that again, in the past 20 years, there have been major changes in our understanding of the development of colorectal cancer. When I was in medical school, the whole idea that that most colorectal cancers come out of a polyp was unheard of. And yet that we now believe that in fact is the sequence that usually follows. Can you say a little bit about the polyp to cancer hypothesis? Because that idea, I think, is what dominates our screening approach. It really makes screening effective.
Right. So the polyp to cancer hypothesis was born out from the observation that if you sequence the genes on the early polyp, late polyp, or early cancer or late cancer, you tend to accumulate more key mutations in the key genes. And that really has borne out not only scientifically but also on the clinical side. And the idea for colonoscopy and the screening is we catch the colon cancer at early stage, preferably before they turn into aggressive cancer.
Right.
Right,
So
so you
that's
catch-
where the screening is important, because a polyp isn't going to give you symptoms most of the time unless it's a really large obstructive polyp. But so screening really is what's going to get the person that needs medical attention to medical attention. But conversely, for rectal cancer, and this is where I want to spend maybe half a minute talking about, there are maybe other signs and symptoms, right, in folks, as you mentioned, under 40 where this incidence is climbing.
Right.
There are certain symptoms that a patient can look for or recognize and seek medical help before the cancer has progressed. What would those be?
Most common symptoms are blood in the stool,
Okay.
and also the feeling that you have to go to the bathroom, but if you sit, nothing comes out. And also the change of bowel habit. Either you become more constipated, or you're getting more frequent bowel movements. Those are the most common presenting symptoms.
So the blood in the stool can also probably be chalked up to hemorrhoids, right? Especially if somebody knows that they have a history of hemorrhoids, and I think it takes a lot to sort of tease that out. When is it? Is there any distinguishing feature between bleeding from hemorrhoids or bleeding from a rectal mass, or is that more?
It is
just
really hard to distinguish
Yeah.
from the patient's perspective, and I think that's why it's important to have your, the symptoms checked up by colorectal surgeons.
Right.
The case in point is I had a patient who was 24 years old and had a blood in the rectum for a few months, and every time she had that incident, she just attributed that to a hemorrhoids, and a month turned into years, and then finally she was diagnosed with a locally invasive rectal cancer. So, as I said, colon cancer affects mostly patients over the age of 50, but incidence of the rectal cancer has been increasing steadily in the younger population.
So any blood in the stool really should be brought to medical attention.
And it's not just the rectal, the whole concept behind checking stool for occult blood was,
Right.
the presumption was that these polyps were
They
bleeding.
do bleed,
and
except
that
you don't see it in most cases,
you
right?
may
You
not
don't
see
see
it.
it with the naked eye.
That's why you need the chemical test. Anyway, we've run out of time in this segment. When we come back, we're going to talk a little bit about colon cancer and some of our newer approaches to it, because it's really changed dramatically, and I think for the patient's standpoint, very much for the best. So we'll talk more about this after a short break. Hi, Vicki and I are back with Dr. Jun-Ho Shin, colorectal surgeon, talking about colorectal cancer.
June, welcome back. And we spent a lot of time in the earlier segment talking a lot about screening, and you have a personal story actually that's impacted you directly.
A doctor who walks the walk.
Yeah. So why don't you tell us that?
Sure. This is the story that I share with some of my patients too. Patients ask me like, I am 80 years old. Do I still need the colonoscopy? And I ask them, have you ever had a colonoscopy? And they say no. Then I tell them, I think you should have one. My mother was 78. She's 80 now, but 2 years ago she underwent her first colonoscopy after much prodding and persuasions and almost threatening from me. And she was found to have a large polyp in her rectum, and which was removed. And she stayed in the hospital overnight as a precaution, but that was her end of the story. She didn't require any major surgery, temporary stoma, or any other complications. Had she not have done a colonoscopy 2 years ago, and she's otherwise healthy, she probably developed colon cancer, or rectal cancer rather, by now. So,
And I think a lot of people feel, well, I'm old, so what? But it's a very unpleasant experience to have uncontrolled
Invasive
colorectal cancer.
Correct. Advanced colon cancer can obstruct, so you can have a blockage. They can perforate, so you can get septic. And this is not a very pleasant way to spend your last days of your life.
Right.
I should also point out, not all polyps are precancerous. I do want our viewers at home to understand that. So there are specific types, aren't there?
Correct. So there are certain types of the polyp, which is a hypoplastic polyp, which is commonly found in a very small size, especially at the rectum. They are not precancerous.
So if you're sitting at home and you've had a colonoscopy, and
Don't misunderstand
that some of them are not precancerous, but the adenomatous polyps, the villus adenomas, are considered precancerous and need to be removed.
And it's always much easier, correct me if I'm wrong, to remove them in the GI lab as you're getting your colonoscopy, rather than when they're relatively small, as opposed to having more involved surgery. And thankfully, from everything that I understand, we're not seeing a lot of progressed colorectal cancer these days because of screening programs like this that are in place. But there are still folks that need to go to surgery and have larger masses removed. Can you talk a little bit about advances in surgical treatment of colorectal cancer?
Sure. So last decade has seen a real advance in terms of the surgical technique. since the 1990s, the laparoscopy has really revolutionized the cancer in the colon cancer surgery and the rectal cancer surgery. In the last few years, robotics also introduced and helps facilitate dissection in the rectum, which can be sometimes difficult.
Yeah, I think a lot of people didn't realize that or don't realize it, but the rectal cancer sits way down in the pelvis. I'm talking to a surgeon who knows this far better than I do. But I just remember back when I was younger, the surgeon, it was technically tough to get in there and do the stuff that was necessary to remove the cancer, right? It was physically difficult, and these instruments have changed all that.
Correct. I mean, laparoscopic surgery to an extent and the robotic surgery really changed the way we can access the pelvis surgically and do a surgery more safely and oncologic sound operations.
It also means for the patient less of a recovery time, is that right? And less of a hospital stay. I mean, you mentioned that your mother had a procedure where she stayed overnight as a precaution, probably given her age, I would imagine, but otherwise probably could have gone home the same day.
Yes.
And I think for a lot of these surgeries, laparoscopic, robotic, the advantage to the patient is that they go home pretty quickly. Is that fair to say?
It is, yes. The laparoscopic and robotic surgery, the patient's hospital stay is usually about 3 days shorter in average. And also, if we do even more minimally invasive surgery on the rectum, such as one my mother had, the hospital stay is usually 1 day. And that I just want to touch base on a new technique called a TAMIS. It's a transanal minimally invasive surgery, and that's
TAMIS, transanal minimally invasive surgery.
Right.
Go ahead, tell us more about this.
And this is for the polyp is too big to be removed endoscopically, or the very early stage of the rectal cancer. We use a laparoscopic instruments to remove those polyp or early cancer through the rectum, and the hospital stay is minimal. The recovery is fairly quick. And the oncologic result on the early rectal cancer has been very favorable.
So this means there's no cut in the abdomen whatsoever. The cut is made through the colon or through the rectum in order to now this is to take the tumor out. Mm-hmm. This is part of a larger movement in surgery called node surgery, natural orifice surgery. Yeah. Mm-hmm. And maybe just say a few words about that, because I think that's probably the next step that we're going to be seeing. We actually recently did, I believe, an appendectomy using node surgery at Norwalk Hospital. Yeah.
I see. I mean, node surgery is not just limited to the colorectal surgery. People have done a cholecystectomy, removing the gallbladder through the stomach, and removing the gallbladder or appendix through either cervix or the stomach. So I would say it is not ready for the prime time, but this is something that we're going to see a lot more in the next decade.
And again, because it reduces all the things we talked about, patient discomfort, length of stay, any effect on infection rates and things like that as well?
Yeah, I guess a lot of people would say, my God, how can you stick an instrument through the colon or through the rectum and have it be a sterile operation?
Right.
Right. So far, the transgastric approach through the stomach hasn't really showed that there is increased risk of the infections.
How about the TAMIS procedure? How do you sterilize then the rectum using washes or things before you put the instruments in?
Yes, we do the bowel prep just like colonoscopy, and I wash the rectum with a diluted betadine, the sterilizing agent. But in general, the anorectal area is fairly resistant to a infection. We take precautions, but the infection rate is fairly low.
And a question, as a patient or a layperson at home, you've got a cancer that's a couple of inches in diameter, you've got colon that you're taking out on either side of it, and some other tissues, and yet you have these small incisions. How do you get it out without having a nice big incision?
I see. Some of the skin incisions, actually, you can, the skin can be stretched to a certain degree, so we can take out the specimen through an incision that looks smaller than the specimen.
Yeah, I think that's a good point to make for those that are interested in the technicalities, like you said.
I know for some organs, and I have no idea with colorectal surgery, they bag the organs, and then they'll chop them up, like with a kidney or a hysterectomy. I think they'll do do that. Do you do that, or do you just pull the tissue out through the?
No, we try to take it out intact because so that the pathologist
Right.
can evaluate the specimen accurately.
Is there any risk of implanting tumor along the pathway that you pull it out through the skin?
Certainly there is, and that's this is just a historic note, but that was the major concern when the laparoscopy was first introduced, but that didn't bore out to be the truth.
Okay. What about other therapies? So we touched on some of the surgical advances. Are there non-surgical treatments also for colorectal cancer once you've had the surgery done and the tumors removed? Do some folks qualify for either chemotherapy or radiation? Can you talk a little bit about that?
Yes, I think that's another major advance over the last two decades. In mid 80s, when the chemotherapeutic agents were limited to two choices, the average survival for the last stage 4 colon cancer, was about 1 year. Now it is extended to about 26 months. So it's improvement. I mean, it may sound small, but this is 100% improvement in terms of the average survival of the most advanced colon cancer.
Okay.
And the point I want to cross to the patients is, if you need adjuvant chemotherapy, meaning that if you're doing a chemotherapy after the surgery, overall the chemotherapeutic agents for the colon cancer is very well tolerated. You don't necessarily lose hair, you don't vomit, and most people work through the 6 months of chemotherapy trials.
Okay.
Yeah. And we've got about a minute left, but maybe you just could say a couple of words about adjuvant therapy, because people would say, well, you took the tumor out. Why in the world do I need additional therapy? It's gone, isn't it?
Right. So we can distinguish between macroscopic or microscopic cancers. We remove what we can see through the naked eyes and feel, but there could be microscopic tumor cells left behind, and that's what chemotherapy comes in.
So it's really a mop-up
looking
operation.
to kill anything else that might have escaped or can't
Right.
be seen by the naked
And
eye.
we
I think
can
that's an
determine
important point. Yeah.
And we can determine who's at risk for that based upon the stage of the disease, or how
Right.
large the tumor is, or what it looks like under the microscope, so that we know that there's statistically a higher likelihood we've left some cells behind.
Yeah.
We're going to ask you to stay behind and help us answer the health question, if we may. And Vicki and I'll be back after these messages.
Here's this week's viewer question. What can you do to prevent colon cancer? And with us, we have our expert,
Yes.
our colorectal surgeon himself, to
So
help
what
us
can we
answer
do to
it.
put you out of business?
I think the most important thing is to know your family history. Is there anybody in your family who has a colon cancer, especially at younger age? Second thing is, do a regular colonoscopy. Once you hit 50 years, you should get your first screening colonoscopy, and then from then on, you should get a regular screening colonoscopy.
And I know they say to start even earlier if you have a relative who has a first-degree relative who has cancer at a young age.
Correct.
I think they say 10 years before.
10 years before.
Younger than the age of your brother or sister or mother when they had their
Right.
colon cancer.
Also to recognize, I would say, right, any changes in your bowel habits, signs and symptoms that you may have something going on that may be more than just a hemorrhoid or things like that we talked about. But what about I'm sure there are a lot of perceptions out there that if you avoid certain foods or if you take such and such supplement, you may be able to prevent colon cancer or any other cancers. Is there any truth to, and I don't know if you know of anything in particular that's out there?
Well, we talked a little bit about fiber, so a high fiber
Right.
diet, low red meat, but I know there's been some talk about folic acid, some talk about aspirin and similar drugs. What's the state of knowledge about that?
Okay. So aspirin, to some degree, decreased the inflammation in the colon, which inflammation thought to be related to developing colon cancer. So I think there is a certain degree of protection from aspirin-related products. There was some, in the past, there has been interest in the selenium and other trace minerals and the protective effects of the colon cancer. Vitamin D could be one of them. The degree of protection from those agents probably, I would say, modest. So you should not really rely on those things.
So just because you're taking aspirin a day doesn't get you out of your colonoscopy.
Right,
Correct.
Right, nicely put.
Yes. So I think that's that's all we have time for. But the real message for everybody at home is to make sure you get that colonoscopy when it's appropriate. And so if you at home would have a question you'd like to ask on Health Talk here on TV, please contact Vicki and me at healthtalk@norwalkhealth.org.
We would like to thank our guest today, Dr. Junho Shin, for coming on our show, and we'll see you next week on Health Talk.
Bye-bye, and get your colonoscopy.